Hi everyone, it's really great to be here. Nice to see some friends and even one of my partners sitting here. So I'm going to talk a little bit about gas embolism in liver surgery. So we all love MIS liver resections, otherwise we wouldn't be in SAGES. And we know that there's a huge advantages for the patients to have minimally invasive surgery. But sometimes bad things happen. Even if you plan really well and you're really, really trying to do everything perfect, some things can happen. This is only one example. And I'm not going to talk about what we did here because I knew the previous speaker was speaking about it as well, so I didn't get into it, but things can happen. So what is exactly a gas emboli? This is actually, I have to give the credit to one of our previous fellows, Toro Goto, who is a very good, talented, he's doing all these paintings, and actually that's how we used to prepare for all our operating rooms. So we used to have this kind of pictures before every procedure. As you can see here, basically what we're talking about is when we're doing laparoscopic liver resection, we have a hole in one of the veins, and some gas is trapping in the vein, and then from there going with the blood into the heart, and then depends whether or not to go to the lungs, or if we have a patent foramen ovale, it can go also to the other side, and then from there causing also a stroke or even a coronary event. We know that we're using CO2 because it's soluble, it's no odor to it, it's very cheap, and of course it's less dangerous from comparing to air, but still can cause a lot of issues. The percentage of the gas emboli to happening in the laparoscopic or robotic liver procedures is about 0.15%, maybe a little bit more. But it's still there, and when it happens, it's bad. So we spoke a little bit about this balance with the CVP and intra-abdominal pressure in the previous talk, but what's important to know is that as much as you put the intra-abdominal pressure higher and you prevent the bleeding from being very, you kind of control the bleeding better, but on the flip side of it, if you have a high intra-abdominal pressure, you can cause the gas emboli. The CVP, we're asking anesthesia not to give fluids, at least most of us, not to give fluids during the procedure to keep the CVP very low. So these two are things that we have to keep an eye on during the case. If they're equal, then there is not a problem, but they rarely the same pressure. So our protocol that most of us use in Toronto is, of course, general anesthesia with everything comes with it. And then we also have most of the patients have arterial line and central line. And we ask the anesthesia to keep the CVP very, very low. And basically, we limit the amount of fluid that we give during the case. For the most of the surgeons, the amount of fluid that we ask them to give while we're going through the liver is about up to 150 cc. So we keep the low CVP, we reverse Trendelenburg as well. The pneumoperitoneum is relatively pretty high, and we do a Pringle maneuver, as you can see here, the illustration. The way we do it, as mentioned also in the previous talk, we do it from the outside, as you can see here in the demonstration using a chest tube. Also decrease tidal volume and then decrease PEEP. So this is actually a paper that mentioned also before. This paper is a very interesting one that was published in the Annals of Surgery a few years ago, that they looked at actually in a pig's lab. And what's interesting here is that they show, if you look at the graph here, so on the pneumoperitoneum side, towards the right side, it's a higher and higher pressure, and on the CVP, on the y-axis, basically, as much as you're going higher is the higher CVP. If you go on the right side of the equilibrium, which is the line that goes in the middle of the screen, you have a higher risk of gas emboli. If you're going to the left side, you have a higher risk of bleeding. What they showed that was very interesting and pretty new is that the airway pressure is very important actually as well. And what they showed that it's very, very interesting that the airway pressure, if it's going high and high, it's very high. It's very difficult for you to almost impossible to control the bleeding risk because the pneumoperitoneum, even if you put it very high, it's not going to stop the bleeding. So basically, you can see here, they show the relationship between the tidal volume, the airway pressure, and the CVP. And you can see the same point that I was mentioning before. Maybe the air pressure is something that is better to control rather than the pneumoperitoneum. So then, next step, how do we identify the problem? So when the anesthesiologist is starting to tell you things like what's going on there, or something happens, or did something went wrong, then you know that something is going on, even if you didn't notice it before. Sometimes, we make a small hole in the vein, we don't really tell anyone, and then there's a problem of communication. But then also these other things, right? You have an open vein somewhere, and then you can have a sudden increase in the end-tidal CO2 that usually that's the first time that anesthesia will say to us something is going on because the end-tidal volume is very high. We can even get, if it's worse, we can get into hemodynamic instability, hypoxemia, and then in the worst cases, acidosis and heart failure. And then as we will mention in a minute also, if you have a patent foramen ovale, that can be even like stroke and collapse. We actually had a very bad case, not in laparoscopic surgery, very recently in a liver transplantation, that obviously it was also air emboli together with it, and the patient woke up with hemiplegia. He actually recovered very well and left the hospital, but it's something that always worth to keep in mind, and that was in an open procedure that is very different. As you can see here, that the first thing you see many times is the end-tidal CO2, and then you can also, the O2 saturation is coming down, the blood pressure is coming down. You can see here on that graph very well when the IVC injury is happening. You will have the end-tidal CO2 down in the scheme is going to be very high, and then the O2 saturation will go low, blood pressure will go low, and the heart rate will go up. The other thing that is very interesting is that if you have any suspicion that something is going on, you can do an intraoperative TE. I would say that we're not doing it at all to the patients unless we have any suspicions for something, but our anesthesiologists are very, very experienced with it. We do it a lot on the transplant side when we do liver transplantation, so all of them are very familiar with it. I would say that there's another paper that I didn't put into the talk. I didn't have enough, I thought it's going to be because of the limitation of time. But if we'll do a TE to all the patients, probably we're going to see in a lot of them some bubbles of air in the atrium, but it's not going to be significant clinically. So that's what we mentioned, just to cerebral infarction that can happen if we have a patent foramen ovale. So just something to keep in mind if we have a patient after the surgery, the next day waking up like this. It's something to keep in mind that can be a reason, and to do some imaging to identify it. So communication is a key. We have to communicate to anesthesiologists to tell them what's going on in our field. Okay, we have a hole, now this is what we're going to do. So they can also prepare and do the things on their side and make it better. And I think the next step for us is, basically we talked about it before, and we talked about all the things that we have to do in order to avoid bleeding. So we talked about low CVP, we talked about reverse Trendelenburg, and pneumoperitoneum is a little bit higher. We talked about the Pringle maneuver that we're doing, but at the end of the day, when that happened, we need to do exactly the opposite of all of these things. So we want to actually increase and give fluids. We want to do actually a Trendelenburg, and to decrease the pneumoperitoneum pressure to about a 9, and or something around that number, because just to prevent increasing the emboli. We of course stop the Pringle maneuver and the increase in the tidal volume and the PEEP. So what about conversion? Of course, sometimes, as you saw before, the things can get wrong also. Sometimes you need to convert. The only thing I would say about that is prepare to it and do it right. So stop the bleeding with some either ATEC or anything else, bulldogs or whatever you have to stop the bleeding when you are still minimally invasive. But then arrange the team, tell everyone that you're about to convert, have everything ready for you, have the retractor ready for you, have the team prepared with all the blood and the fluids that you want in the room, and only then do it. So do it right. That's my team. I could not have done anything without them. Sean is actually here, my partner. Thank you very much.